Welcome to the Jerry Pal Podcast. This is Eric Widera.
This is Alex Smith.
And Alex, I see somebody in the room with us.
We have a guest host today with us. We have Lauren Hunt, who is a nurse postdoctoral fellow here at UCSF and presented the article we're going to discuss today at Journal Club a couple weeks ago. Welcome to Jerry Pal Podcast, Lauren.
Thanks for having me. Hi, everybody.
And we have the lead author of the article I heard online. Is that right, Alex?
That's right. We have the lead author. This is a paper about, in JAMA, effective intensive versus standard blood pressure control on probable dementia, a randomized clinical trial. This is a hot topic. We have Jeff Williamson, who's the lead author, who's chief of geriatrics at Wake Forest, a great place. We know many people. We were talking to Bill Applegate just yesterday. Welcome to the Jerry Pal Podcast, Jeff.
Thank you. Thank you for having me. I've been looking forward to this. Great to be here.
I'm super excited to talk about this. I'm just looking at two different news headlines on this article. One saying intensive blood pressure treatment does not reduce dementia risk, and another one saying it slashes dementia risk. So I'm excited to hear which of those two news articles should I believe. But before we go in the article, Jeff, we always start off with a song recommendation for Alex. Do you have a song for him?
Yes, I lately have been thinking about the song "Old Blue Chair." It's a Kenny Chesney song, so I'm not sure how familiar your audience would be with it, but it reminds me of where I want to be.
It's nice.
Okay, Alex, let's give it a try.
There's a blue rocking chair sitting in the sand, weathered by the storms and a well-oiled hands. It sways back and forth with the help of the winds. It seems to always be there like an old trusted friend. I've read a lot of books, I wrote a few songs, looked at my life, where it's gone. I've seen the world through a bus windshield, but nothing compares to the way that I see it, to the way that I see it, to the way that I see it when I sit in my old blue chair.
That was awesome. Nicely done,
fun.
Alex.
Thank you.
Very good.
That was
Wow.
fun to learn. Thank you very much for that. Thank you,
I
Jeff.
can't wait to download that.
Any particular reason you chose that song besides wanting to sit in that blue chair?
Yeah, I just I think I have a chair like that. I have a few chairs like that, and I just love to think about even the topic we're going to talk about today. And that's a really relaxing place for me. So that's why I chose it.
Great. So we're going to be talking about the Sprint Mind trial. So the JAMA article that came out, effective intensive versus standard blood pressure control on probable dementia. But usually before we go deep into the article, I'd love to hear just how did you get interested in this as a subject? Has this been something that you've been has been an academic lifelong thing that you've been interested in?
Well, I've been very interested for many years in the need to include older adults and the outcomes in clinical trials that are important to older adults, like cognition, like physical function, in clinical trials, in tests of therapy. So often outcomes are disease-based, like stroke or myocardial infarction or mortality, and those are important outcomes. But Sprint, and we have other Sprint articles that actually incorporate what are important to us as geriatricians, and more importantly to our patients. That is, how is this going to affect my physical and cognitive function if I do this? So that's really one of the main reasons that we've started on this journey.
So that brings me to actually one of the issues that came up when we were reading this in Journal Club, which was the issue of generalizability. Because we were struck that actually you guys had excluded people who lived in nursing homes and people with diabetes and people who had a history of stroke. And so then we were wondering if those of us who work in geriatrics would have any patients left after excluding all those people.
Tough questions right up front, Lauren. Whoa! All right.
Yeah, he's just trying to nail me right away.
right off the bat.
It's like a congressional hearing all right off
That's
the
right.
bat.
Good.
That is a great question. This is a common question.
Well, we're going to be asking about your Russian ties.
That's right.
Yeah, that's right. Yeah. There's a lot I could say there, but I won't. Back to the science. So thank you, Lauren, for that question. I think this is one of the most important questions. And I think as geriatricians, we often always think of the subset of the population that we see that is sort of like a cardiologist that might see only people with an ejection fraction of less than 20%. So, but there are a lot of older people out there who are very functional. Half of my practice is people in their 80s and 90s who are driving, independent. I just saw a woman yesterday who is playing tennis. She's just had her 90th birthday. And so all trials have exclusion criteria. And so we as a geriatrician, the goals of care are clearly very different for someone who lives in a nursing home or assisted living. But I'm talking that Sprint was really focused on ambulatory older people who can come to see their physician. And still, I think many of us, even as geriatricians, still see a subset of people, and certainly primary care family practitioners and internists see a lot of people who are older, who are ambulatory and still living a very independent life who would benefit from this therapy. So you're correct. This doesn't cover all the landscape of older people, and it was not meant to be. Just like if you do a cancer trial, is it generalizable to people who don't have cancer? No, we're talking about people who have cancer in a cancer trial. And so I think that's a confusing thing sometimes for geriatricians.
Well, maybe we could take a step back and let's think about what it's been now 3 years since the original Sprint came. 3 years? Has it been that long already? 2 years? 3 years?
3 years.
2015. Right. So it was a randomized controlled trial looking at two different blood pressure target goals of less than 120 versus less than 140. Nearly 10,000 people, 50 years and older. And everybody had to have a blood pressure of somewhere between 130 and 180. And they all had to have some other increased risk for cardiovascular events, like they had to have CKD or cardiovascular disease other than a stroke or an age greater than 75 or Framingham risk score of greater than 10. That a good summary of the Sprint kind of what the population was. And like Lauren said, there were some exclusions.
There are some exclusions, correct.
Stroke, diabetes.
Let me explain those exclusions just very quickly. We excluded people with heart failure because they have to have these medications. And then people with diabetes and prevalent stroke were already having a trial looking at lowering blood pressure. So we didn't want to get halfway through the trial and have to deal with how we're going to incorporate the findings from those trials into our current trial.
And then also importantly, everybody, right? You screened out people with orthostatic hypotension, right?
Yes, we did. We screened out people whose systolic blood pressure fell more than 20 points, I believe. But that is I don't have the paper in front of me from the original paper. But well, yes, we did. And of course, we didn't include anyone whose blood pressure was below 135 to start with. So if your blood pressure fell below 135 or was below 135, you weren't in the trial.
And also importantly, the way we measured blood pressure in the study is probably different than the way most people measure blood pressure in their clinical practices. It was automated. There was periods of silence and quietness. People weren't like here trying to run to their clinic appointment and then get their blood pressure checked right away. And I've talked to Dr. Mark Supiano about this and arguing that, this just doesn't apply to real life, like real clinical practice. We're not measuring blood pressure this way. And his argument is we should. Thoughts on that?
Yes, I think one of the most prevalent risk factors that comes through our practices is hypertension, is blood pressure. And we would not draw blood on people and measure cholesterol or renal function as casually as we measure blood pressure in such an unstandardized way. So I think you're right, and Mark is right, that we need to not accept such a poor quality blood pressure measurement. And yes, Sprint, like all research studies, has a standard measure for blood pressure. And when I see patients now, I tell them, look, we're in our clinic now. We're having people sit still quietly for 5 minutes, and we're measuring their blood pressure and taking the average of 2 readings instead of 3. And so that's the basis on which we perform Sprint. And I think we need to be more careful about that. By the way, we're also looking at how we might improve blood pressure measurement in our non-geriatric practices. And one of the things we're thinking of is maybe measuring blood pressure at the end and having an advanced practice provider, such as Lauren or others, manage the blood pressure. They do a much better job anyway, but measuring blood pressure at the end like we do lab work.
Actually, one of the fellows in the VA Quality Scholars Program just gave a presentation on a project to try to improve blood pressure measurement and just how difficult that was to actually implement in practice. One of the things that we talked about in the group when we were watching it was the idea of maybe even taking blood pressure measurement out of the office setting and moving it into the home and having more regular checks in the home.
I love that idea, Lauren. This is a risk factor that should be owned more by the patient than the healthcare system. It's not that complicated. So many of my patients now, I say, here, I want you to get this automated blood pressure cuff and then send to our team your results after 2 weeks. And that's how we're basing our decisions often.
Great. So in the Sprint trial, people who got the standard treatment had a mean blood pressure of like 135, took nearly 2 medications to control the blood pressure versus 3 meds almost for those in the intensive group. And they almost got to goal, 122. And the big results was, what were the big results of the study?
Wait. Before we get to the results, hold on. That is a big difference. I think we should just note that in previous blood pressure control trials, they haven't been quite as successful. That is a big difference between the two groups. So something worked, right, here? That
one additional medicine?
One additional medicine. And there probably was, what did it take to get these people down? Did they have coaches? Did they have... How aggressive were the study investigators, you and the others, in helping people to achieve these goals?
Yes, another excellent question. First of all, a lot of geriatricians were in Sprint. There were probably 7 or 8 geriatricians in Sprint, maybe half the geriatricians in the country. Not really, but there was both arms had non-medication lifestyle recommendations for getting blood pressure to target, number 1. Number 2, at the beginning, for the first 3 months, all participants were seen monthly to make sure they were at their goal, and then quarterly after that. And there was no additional coaching or anything like that. It was simply one visit quarterly for managing this very common and dangerous risk factor. So we didn't have, a whole 5 people around each participant. It was basically done, and probably half the places it was done in were physicians' offices that are not even academic offices per se. So, but the key was the standardized measurement of blood pressure and attention to detail. And then, of course, when you provide medications at no charge to your patients, well, that shows you how much good you can do in that situation. So all the medications, by the way, 95% of the medications used in Sprint were generic. These weren't, this was not a study that was supported at all by pharmaceutical companies. 5% of the medications were. So very important to say all that.
Yeah, those are key points there. That is an interesting wrinkle to this story. Eric, you were going to ask about what the results were.
Well, the results? Should we talk about the results? Because that was the big thing, right?
I have a question before that.
Okay.
Russian ties.
I promise I'll be nice from now on.
What were you doing in Trump Tower?
I just wanted to ask about how you assessed. You guys had a very robust assessment of cognitive status and dementia, and whether you could just talk about that a little bit. And it seemed like maybe there was some change from the original protocol. When I was reading it, it seemed like there was an original plan to take a sample of everybody, but then you guys ended up doing a cutoff score. But maybe I'm not reading that correctly. So just wondering if you could talk about that.
Yeah, another great question, Lauren. And so this question is intimately tied to the fact that Sprint is very demographically represented. One third of the participants were over the age of 75. One third of the participants were African American. 1 in 10 participants were Hispanic. And so it's a very demographically diverse study. Because of that, there really have not been good screening batteries for cognition that had been well adjusted for age, culture, and socioeconomic background. So we built into the original protocol that at the end of the first year, we would look at and everyone had the basic screening battery, and 30% of the individuals had an entire screening battery that lasted about 1 hour. Everybody got the 20-minute battery. But the bottom line is, at the end of 1 year, we wanted to look and see, to take a pause and see what should be our cutoffs based on the various demographic representations in the trial. And that's why you see that change in the study. We intentionally and purposely set that in there at the beginning of the protocol. Does that make sense?
Yes, definitely. Yeah, and it's interesting. We thought it was interesting that the cutoff score in the MoCA was actually we thought it was kind of low.
Yep.
But then in looking at the average score, it wasn't actually that much lower than the average score.
That's true. And I think, again, if you look at the baseline MoCA scores, which are in the paper, you can see that this was not a cognitively pristine group of individuals. The mean score was 23. I'm not looking at the paper. I should know all this data by heart, and I feel like I do, but you may have it there in front of you. But the bottom line is, and one third of the people over 75 had a gait speed of less than 0.8. So this goes back to your original question. While this was not meant to be representative of people who are cared for and live outside of the home, in a nursing center or whatever, it is fairly diverse in terms of physical and cognitive frailty for ambulatory people.
Alex, can I now talk about the results?
Lauren, should we let him?
Yes.
Okay.
Okay, so original Sprint stopped early because of a 1.2% mortality benefit in the folks who got the intensive treatment. Also, reduction in combined MI, stroke, CHF, heart failure. But the new study, what did you guys find as far as did it affect rates of cognitive impairment, dementia?
Well, it's interesting. At the very beginning of this, you talked about the fact that 2 headlines were common. One says no effect, and another says it's a game changer.
Yeah.
So one of those individuals, one of those headline makers, didn't read the paper.
I wonder which one is it?
And I wonder which one it would be. So, and probably one of the reasons you're talking to me is because there's one of those headlines that maybe has more impact on our field. So, we found, and you quoted the absolute risk reduction, the relative risk reduction. We found a highly significant 20%, 19% reduction in the onset of mild cognitive impairment in the intensive group. So these are people that went from normal to mild cognitive impairment. And in many ways, as a geriatrician, as all of you are, or gerontologists, I'm so sad that we named this mild cognitive impairment, because it has, all of us see people with mild cognitive impairment, and it's milder than dementia, but it has real impact on their daily life in an increasingly technological society. So, being able to prevent or delay this is huge, especially when you have a prevalence of hypertension upwards of 70% in the population. So some 1% drops are not that big, or 1 to 2% absolute, but some are when you think of how many people have the condition that we're studying. So I want to put that in there. So the second thing about the results is, yes, we found a 19% reduction in MCI, which was significant, 0.008. We actually also found a 17% reduction in dementia, but it was not significant. 0.10 was the, and the confidence intervals crossed 1. So what that tells, and if you see, you had more than twice the number of MCI incident cases that we had of dementia. So fortunately for us human beings, dementia doesn't develop rapidly. And so the stopping of the intervention early at 3.5 years, and also, frankly, because after we stopped the intervention, a fairly significant percentage of individuals didn't come back for any additional follow-up because they weren't getting any medication. So those two things probably prevented our ability to have a significant result in dementia. But we are continuing to follow one additional round, and at that point, we may have more clarity on whether the dementia incidence achieves significance or not. Does that help you?
Yeah. So the take home is it reduces mild cognitive impairment, or reduces the risk for mild cognitive impairment. And there seems to be a signal that it reduces dementia, but it's hard to tell because the trial was cut off early. Would that be a good summary?
That's a good summary. And a clue here is that if you combine those two, one thing I've learned from mainly hanging out with heart researchers is their primary endpoints combine many outcomes like heart failure, stroke, MI, death. We didn't do that, and I wish we had have, because if you look at the combined outcome of MCI plus dementia, you can see that it is significant if you look in the JAMA paper. So that tells you that these events, these outcomes were in the same direction and that they were fairly close in terms of percentile. There just wasn't enough of the outcome of dementia.
We could also tell you're hanging out with the cardiologist because of the great titles like Sprint. I remember the newspapers when it came out, should we sprint to a new low blood pressure target? Let's not sprint to judgment.
That's right. No, yeah. One can learn a lot when you hang out with other people. And they learn a lot from us. I think, the other part of this podcast is I really want to encourage gerontologists and geriatricians, get outside of our group. We talk to the choir a lot. Like we say down in the South, we're preaching to the choir. Well, you know what? Some of the most impactful science I've done and have been welcomed is by cardiovascular docs. I remember back at All Hat, I was the only geriatrician. I was just a little baby at that point. And they said, wow, it's just fascinating to have someone in our midst who understands or is interested in aging, because they'd never heard of some of the things we're talking about. So I think all of us who listen to this podcast need to be getting more outside of our own group and sort of integrating ourselves into some of these other conditions and disease states. And we can do a lot, I believe, in that area.
So I got one more question too. Has this changed how you care for older adults in your practice?
Yes, it has. I think like almost all the geriatricians, I expected there to be harm for older people who were lowered to 120. And now I use this, like all clinical trials, just in the clinical interface between me and the patient, it's a starting point for my discussion. So now I say, look, let's see if we can get you into the 120s. If you start feeling poorly, my goal always is to make you function well and feel well. But now, instead of trying to get you to 140, I want to get you down into the 120s, because the patient usually just told me the one thing I fear most, Jeff, is not dying. It's becoming cognitively impaired. And so, yeah, I think if we say we're evidence-based practitioners and we have an ambulatory older person in front of us, then I think that this is the best evidence we have to say, this is the only thing we have that can say we can lower that most feared outcome. And so I use that in my practice a lot. I still have some patients that I can only get from 150 down to 135, and then they feel poorly. But that's okay. We've made a big gain.
Yeah.
But I have a lot of patients. And if you look, there was actually a quality of life paper published in the New England Journal on the Sprint trial, and the quality of life between the two groups on a very extensive battery was not any different. And so I'm surprised often at how many of my patients can actually get there and get there quite safely.
And I just want to, you said your goal is to get him into the 120s, not less than 120. Can you clarify that?
And that's the guidelines. Yes, that's so. Another great question. If you look on the ACC-AHA guidelines, I was the AGS representative to that committee for new blood pressure guidelines, and we only said below 130. And because SPRINT is one trial for sure. By the way, this was also shown to be safe in ACCORD. But when we look at office-based measures of blood pressure, they actually do run about 10 points higher than the standard well-conducted measurement of blood pressure, such as in trials by SPRINT. So we felt we could safely say 130, below 130, but getting to 120 in an office-based practice, the way the quality of the measurement is now, I don't think we can say that.
It's an important point. I want to ask we have a question here, Jeff, from Twitter. We have a few different questions. First one is from David Dorr, who says, given the trend you see, what duration of follow-up or increase in N would you need to achieve significance if the point estimate of the primary outcome was truth? And you'd have to get out your calculator there.
Yeah, well, we're actually, this is a timely question because we're resubmitting this now for one additional follow-up. We believe pretty strongly that if we have one additional follow-up for 2 years, so that would be somewhere between 7.5 and 8.5 years, that we will definitively know whether dementia was also prevented or the risk for dementia was reduced. So I think we also feel likely that if we had done treatment to what we initially planned, if we had treated to 5 years rather than 3.5 years, we probably would have this answer. So that's a great question. I'll just say one more thing about that is there needs to be some advances in trials, especially for this age group of, cardiovascular endpoints and mortality are not the most important endpoint to them. So stopping a trial because we had fewer cases of heart failure is probably not the most important endpoint for older people. So we need to do, and we have proposed some designs that would make cognition and physical function the primary and the others the secondary outcome.
Okay, and then we got a couple of softballs tossed to you from Mark Supiano here on Twitter, who says, what other interventions for older adults have been demonstrated to improve CVD outcomes and mortality and prevent cognitive impairment? If this intervention was a new treatment, how much would we be willing to pay for it?
I need to give Mark that $35. I promise him. No, I didn't know he would ask the question, but nevertheless, there are no other treatments that have been shown to be effective for the heart and the brain, and there are no other treatments, period, that have been shown effective for the brain. So, thank you for that question, Mark. And I think that again, because this is generic, again, I tell my patients, even if you have to be on 3 medications a day, the cost is typically less than what it would cost to have a cell phone in your pocket every month. And so to preserve your cognition, that's every penny is important, but this is one of the most important you will spend.
It's great. Well, so we can't end on an easy question like that. We got to go back to the well here. Going to Lauren.
Okay. Hit me, Lauren. Hit me with your best shot. I just been the song that I said.
Well, I had one comment and then I have a question. I just wanted to follow up on what you had said earlier about integrating geriatrics into other professions. And Alex and I just wrote an editorial where we talk about exactly this, about how there's really just insufficient number of geriatric and palliative care providers, and we really need to be training people in other fields and primary care on these issues. And,
I totally agree. I'll just give you, Lauren, one example of that. I'm sorry, I love to talk too, but we're hiring now someone who's board certified in emergency medicine and is finishing a palliative medicine fellowship with us. And that person is already changing how the emergency room cares for dying people. So I completely agree with what you just said.
All right. And so the question is, so there was a figure in the addendum, and it showed, how you guys had really great results in lowering the blood pressure in the treatment group, and they got to an average of 120, and the other group is in the 130s to 140s for the first 4 years, and then the trials ended early, and then of course everybody now it's clear that this treatment is really effective and reduces cognitive impairment, reduces all these cardiovascular poor outcomes, and so everybody in the control group went to their blood pressure got lower, right? After the trial ended?
The control group, actually, the standard treatment group stayed at 135 to 136 through the treatment and through the extended follow-up off of research therapy.
Right. And then what happened to the treatment group?
So the treatment group, the intensive group, rose steadily until they leveled off at 129, a systolic blood pressure of 129, which is still below the current guidelines of 130. But it does show you that once you stop providing medications at no charge and making this a focus of the visit, all of a sudden the blood pressure starts to rise.
So what do you think are how we can change this? How do we make it so that we have this great intervention and we can keep it going in the real world?
Well, two things. One, again, I would say at least the intensive group is below, is at guideline, so that's good. I can't say that they're undertreated because they were 129 when we did the last follow-up visit on average. So, but I do think this is one of the great opportunities of electronic health systems. Mainly, they've been a billing tool now, but here, and I suspect where you are, we can now begin to see what are the blood pressures of specific patients and of the panel of specific providers to say, look, we don't expect all your patients, to be below 130, but on average, we've shown that you can get most of your patients, on average, we can get your average to below 130. So I think we need to start using electronic health record keeping as a way to help providers not provide another banner, but to help them maybe on a quarterly basis, just say, hey, where are my blood pressures in my panel? So there's some things like that need to be done. We need to have some innovation in our system that helps us understand what's important, and this is a really important risk factor.
Well, I want to thank you tremendously for joining us today, and really for doing this research too. Because, like you said, I think for a lot of geriatricians, initially when we saw this, we think, "Oh my God, this can't be true!" Like, there's something not right about this. And when you actually read the article, it's a great article. The original Sprint, the frailty article. So I just want to say a big thank you.
Yeah, thank you so much, Jeff.
Thank you all. I will say, too, even as a geriatrician, when I saw this result, I was thinking, gosh, I spend most of my days taking people off of medicine. And so,
It's like
and
an
I still
anthem
do
of
that,
it.
by the way. But I'm more and more even adjusting my thing to say, I want people to be on the correct and the most important medicines. There are a lot of medicines that older people don't need. But I think hypertension therapy is one of those medications where we need to be very careful before we start just backing off of everyone, especially fairly healthy older people.
Mm-hmm. Terrific.
Well, maybe, Alex, do you want to end with a little bit of a song?
A little bit more of the song.
Thank you.
From the chair I've caught a few fish and some rays. I've watched boats sail in and out of cinnamon bays. I let go of a lover that took a piece of my heart. I prayed many times for forgiveness and a brand new start. I've read a lot of books, I wrote a few songs, I looked at my life, where it's gone. I've seen the world through a bus windshield, but nothing compares to the way that I feel, to the way that I see it, to the way that I see it when I sit in that old blue chair.
Wonderful.
That was wonderful, Alex.
Thank you,
Jeff, again, big thank you for joining us.
Huge
All of
thank
our
you.
listeners, thank you for joining us this week. I I forgot what my extra
Well, usually
is.
usually you say, if you're listening to us on iTunes or some other medium, please make sure to like us.
What Alex said.
We'll see you again next week.
We'll see you again next week.
Bye.
Goodbye, everybody.